Now to another case which is a bit longer and a bit, I would say, more spectacular when you look at the clinics. It's a case I will call fibrosis. It is a patient who is 40 years old, and he has systemic disease. I will not tell you which systemic disease. This is for you to find out. And he also has shortness of breath. That's how he came to me. And at this point, the diagnosis of a systemic disease was already made. Back to the images, back to the echocardiogram. So you see the patient came in 2005, so that is 7 years ago, and I've been following him since then. And this is the first echocardiogram I did on him. You see there's fairly rapid heart rate. It's for you to find out how left ventricle function is, but one thing is clear, the left atrium is dilated. The aorta is normal. I don't know if any of you see anything on the mitral valve, but there is significant mitral regurgitation. So we see that there is a jet that goes into the left atrium, which is a bit eccentric, more towards the posterior regions of the left atrium. Measuring the size of the aortic root in the left atrium again shows you that in the M mode, 50 millimeters is certainly dilated. Now I'm showing this even though I'm pretty sure that this is a measurement that you will probably need to do anymore. I think the M mode of the aorta and the left atrium is something that is more of the past and something that we've done at the times of M mode. And nowadays, the better way of quantifying left atrial size is by measuring the diameter and even more so the volumes. We'll do that later just to give you a feeling of how these measurements that I show you here compare with the 2D measurements. Okay, now here's the short axis view, the mitral valve, and now we can apply what we learned in the previous case. Where do you see the origin of the mitral valve? Okay, well, it's right here, and this is the posterior medial commissure of the mitral valve. This would be the anterolateral, posterior medial. So very simple. Again, we cannot really quantify the degree of mitral regurgitation here because we're just cutting right transversely through the jet, and we do not know the extensions, and it's very difficult to see the exact vena contracta in this view, but still it helps us to determine where the origin of the jet is. This is now the 4-chamber view, and some of you will now say aha because you might already know what the diagnosis is. The image quality is not very good, but one thing which is quite clear is that the left ventricle is really hypercontractile. So if we measure the size of the left ventricle, let me just go through this. This is end diastole. Very difficult to see the lateral wall, but I would assume it's somewhere here. Okay, we have 52. Remember, 50, 55, that's kind of where the range starts of a dilated left ventricle. So it's not very large, but it seems to be dilated. It was a normal-sized man, by the way. Again, hyperdynamic left ventricle function. We have the large atrium. Let me just measure the left atrium. I'll do both the distance measurements again and the volume measurements. Here, this is the length of 59. Okay, and if we want to do the volume, something like this. This is 124 milliliters, which is a large left atrium. Okay, keep this in mind. Now to diastolic function. Because the patient has a fairly high heart rate, there's a bit of fusion of the E and the A wave. So it's very difficult to appreciate what diastolic function really is. But one thing is clear. There's a very steep deceleration time. So this does depict elevated filling pressures. However, we have to be cautious because the patient has a mitral regurgitation. So obviously, we'd expect high filling pressures in patients who have mitral regurgitation. This is the 2-chamber view. Okay, does this patient have anything up here? You probably noticed that there is an area up here which is fairly suspicious. Okay, I won't comment on that anymore. Just look at it. because the question will be coming for you. Okay, here is the question. Which systemic disease does he actually have? Okay, I hope you can see it this time. I can see people voting. Aha. So I guess a lot of you are true echo experts already. Maybe some of you have even seen this image loop before, because I think I even used it in my presentation in the masterclass. Okay, let's close the poll. Okay, so 59% of you have actually made the right diagnosis of a disease which is very, very, very uncommon, endomyocardial fibrosis. At least we here in Europe don't see it very frequently, because it is a disease which is more common in other countries where we have parasitic infection. But let me go back to my presentation and just show you what endomyocardial fibrosis actually is. It's a leukoproliferative disorder where we have an increased number of eosinophilic cells, and what happens is that there is kind of an eosinophilic infiltration which is located in the endocardium and which causes those infiltrations that we just saw in the echocardiogram, and we'll go back to them and I'll show you these infiltrations once more. And this is a disease which also affects the myocardium actually, and it is in the group of restrictive cardiomyopathy. Okay, so let me go back to the presentation. This here is the eosinophilic infiltrate, where we have a very echogenic apex. The endocardium is very thick. It might look like a thrombus. People might confuse it with a thrombus, but it's not a thrombus. The big key finding here is that the patient has normal wall motion right here in the apex. You would not find a thrombus in normal wall motion. So this is typical of an eosinophilic infiltrate. I just got a question from Yvonne, and she asked, is there a relation to Churg-Strauss syndrome? Yes, absolutely. Churg-Strauss syndrome also causes eosinophilic infiltrations. In this case, the patient did not have a Churg-Strauss syndrome, but he had a genetic disorder causing hypereosinophilia. But we have seen these infiltrates in patients with Churg-Strauss as well. So this is one of the pathologies which is in the group of the hypereosinophilic syndrome. So very good comment. Okay, but coming back to this pathology, the problem is that this thickening and fibrosis also shadows us the view to the mitral valve. So it's very difficult to image him, and we had to use atypical views to really look at the degree of mitral regurgitation. And here is mitral regurgitation now from a kind of an apical long axis view, and you will appreciate that this is very severe. And so when we saw this, it was clear that the patient must have dyspnea because he has severe mitral regurgitation. Now, the other problem this patient has is he has also restrictive cardiomyopathy. And if you have a restrictive cardiomyopathy, the myocardium is also stiffer. It cannot expand, and it cannot adapt the way other ventricles would in the case of mitral regurgitation. So what he's doing, he's trying to adapt by increasing the heart rate. So he had very, very high heart rates, in this case 101, and even more on other occasions. So what do we do with this patient now? We have a patient who has hypereosinophilia with a restrictive cardiomyopathy, still good left ventricular function, and with very severe mitral regurgitation. And the other question is, why does the patient have mitral regurgitation? We do not really see any pathology on the mitral valve. At least I didn't. This is, again, the apical long axis view. Okay, we can't see the mitral valve very nicely, but it was not clear to us what the patient really had. And what we did is, obviously, we first performed symptomatic therapy. We gave him diuretics, and that really relieved the symptoms. He did better, but dyspnea remained, and he needed fairly high doses of diuretics. And we followed the patient, and he got therapy with interferon. At that time, this is the therapy of choice for these patients, and he was doing fine. Um, yes, I just a question got in from Andreas. Yes, this is also left cardiomyopathy, which is actually just a different term. Endocarditis Löffler is basically just that. It's the hypereosinophilic syndrome. There's just more names for the same pathology. Okay. Another question we got from Alan, how is the strain? Well, I would like to know, at this time we did not have the system available to measure the strain, and then we tried to do that retrospectively. The only problem was he had so much shadowing from this apical region that we were not able to perform strain. But it would be a very interesting question, because I would actually assume that the patient has subclinical left ventricular dysfunction. Because he has restrictive cardiomyopathy, we see that very frequently in patients where we still have a normal left ventricle. But coming back to the patient, he got interferon. The only problem was he did not tolerate that very well. He got bouts of fever, and he was doing not very well with this interferon, but there was nothing else that could be done. The eosinophilic cells dropped a bit, but they did not go back to normal. Okay, so let me go back now to what we did next. Well, the next thing that happened was a new drug came out, and this was imatinib, which is Gleevec. The substance is called Gleevec. Is the name we have as for the product here in Austria, at least. And this was a real breakthrough, because it was a targeted therapy exactly for his pathology. And he got this drug therapy, and he improved significantly with respect to his eosinophilic cells. Let me show you how the echo changed. Let me go back to the patient. Okay. And this is now his image. Okay, you see, first of all, his heart rate is slower. It's still quite high, but it's not as high as it used to be. It's somewhere in the range of 80. And he was doing much, much better. He needed much less diuretics. And now look at mitral regurgitation. Mitral regurgitation has actually gotten less, significantly less. Okay. The aortic valve, there was nothing wrong with that in the first place. Okay, let me show you the short axis view. See, we have very good left ventricular function. Okay, there's nothing wrong with the ventricle here. Again, the hypereosinophilic infiltrate right here at the apex, this will not vanish. In the initial phase, it did get a little smaller, but I guess this is so fibrotic that even if the eosinophilic cells are now normal, this will not vanish. But the ventricle seems to be smaller. Let's measure this. Yeah, as a matter of fact, it is. It's 49. We had 52, maybe 53 before, so it is smaller. Here is diastolic function. Now we can appreciate that he has maybe something in between restrictive filling and somewhere in between pseudonormal and relaxation pattern. Here is the Doppler finding at the mitral annulus. This is a question that was also asked by one of our users just right now. And what you see is that the patient does have fairly good, fairly high E prime velocity. So what does this mean? This means that he probably does not have very high filling pressures. At the first study, we did not perform a tissue Doppler at the mitral annulus, but here now, this was 3 years later, we did, and at least we can say at this time point, his filling pressures were not very high. Okay, so this was the image at follow-up, and we were very happy because he was doing fine. From here, the MR looks a bit more, but still much less than it was initially. Here you can see the mitral regurgitation now. The question now is why all of a sudden is mitral regurgitation less? Well, I think, and this is my personal belief, is that it is related to the drop in the eosinophilic cells, that the Gleevec that he was taking was actually helping him and was actually making it easier for him to was actually treating the mitral valve pathology as well. So this is at least my thoughts on it, because even though we gave the patients diuretic initially and his mitral regurgitation got a bit better, it was not as little as it is here after the Gleevec therapy was initiated. And this also goes quite nicely with the BNP values we had at the time, and it also fitted nicely with the clinical status of the patient. Okay, so here you can see the mitral valve, and we think that the endocardium was not only affected here in the apex, but also on the mitral valve, and that there was some degree of fibrosis, which led to this mitral regurgitation, which was at least partially reversible. So everything was fine. We were very happy. However, the story continues. After some time, the patient came, again with mitral regurgitation. Let me show you this study. Okay. Now he was on therapy. His heart rate again was going up. He was now in the range of 100. He was again under diuretics, and the doses he needed were increasing. And he was in a very poor condition. The left ventricle is still fairly okay. Does not seem that the patient has significant left ventricular dysfunction. The infiltrate is not changing. It's the same. Okay? Mitral regurgitation is more than it was before. His BNP levels were fairly high. It was almost 14,000. Very high values. And here is just a close-up view of these infiltrates again. Mitral regurgitation, the mitral valve again. Okay, otherwise nothing much different. Here is just the tricuspid regurgitant signal. You can see that the patient has fairly high pulmonary pressure. If you add maybe 10 to this for the right atrial pressure, we're somewhere in the range of 57 to almost 60 millimeters of mercury. Okay, we just got a question in from Yvonne again. She asked the question if there could be a flail leaflet or chordal rupture. Good question. Certainly this is something you have to consider. Now, obviously it's possible because the patient has fibrosis of the mitral valve, and it could very easily be that they're susceptible to chordal rupture. Now, we've never seen a case of restrictive cardiomyopathy with chordal rupture before, but it is certainly something which is possible. And we were considering this. Still, the question is what we should do next. And I don't know what your opinion on this case is, but if we just put all these things together, the patient has symptomatic mitral regurgitation and good left ventricular function. So in reality, this is an indication for cardiac surgery. And this is also what we proposed to the patient. Before, we were not so reluctant to really send him to surgery because we were afraid that the mitral valve is very difficult to really operate. Simply because the mitral valve is thickened. You do not know exactly what to expect in this kind of pathology. It's not a normal mitral valve that one just simply operates. And obviously one could put a prosthesis in, but we were not happy to give a prosthesis in this patient who was fairly young. So at least a mechanical prosthesis. So what we did was we brought the patient to TE. The only problem was that the patient was so dyspneic at that time that we were not able to perform the TE study. So we just simply sent him right away to surgery and said, okay, we'll do the TE study during surgery. The anesthesiologists do that, and they will see what the pathology is like, and they can then obviously operate. In addition, obviously, the surgeons will take a look at the valve as well. So he was operated, and yes, operation went fairly okay. He had no major problems, and he was on the ward, but he somehow did not really improve the way we expected him to improve. So what happened was that I brought him down again to the lab to take another look at his mitral valve, and I will show you the mitral valve now right after surgery. Okay, first of all, the patient has a bit of dysynchrony. This is the mitral annular ring that was put in place. This is the anterior leaflet and the posterior leaflet. Okay, and now this looked fairly okay at this point. Left ventricular function is not so good. He had atrial fibrillation at the time, so I first thought, well, maybe it's simply because he now has atrial fibrillation. That is why he's not improving the way I would like him to. He had a small pericardial effusion right here in the inferior part. Okay. And then I saw this. Now, the patient was full of bandages, and it was very difficult to image, but one thing was clear. The patient, again, had mitral regurgitation. And this was very difficult to quantify, but I had the impression this was something that probably could not be left the way it is. Now, it's very difficult to go up to a patient and tell them just through, what was it, maybe 5 or 6 days after operation, well, you need to go again. So we kind of sat together with the surgeon and said, you know what, let's try to stabilize him and see how much he really is. Maybe we can do without surgery, and we'll just send him off to rehab and maybe call him back afterwards. But what happened was, and that was very, very dramatic, we sent the patient home. Only 1 day later he was back, and he was in pulmonary edema. He was really, really in pulmonary edema. And in addition, he had fever, he had signs of pneumonia on the chest x-ray, and we simply brought him to the intensive care and reoperated him the next day. And this time everything went perfect. He had no residual mitral regurgitation, and he is still doing fine. I saw him, what was that, maybe just 2 or 3 weeks ago, and he has a normal left ventricular function, he has sinus rhythm, and he's really doing fine. But we talked to the surgeons and discussed what the problem was, and he said, well, the problem was that the valve was very, very tender, and it was partially fibrotic, and the stitches just simply didn't hold. And he thought, at least that's what he said, that one of the stitches must have simply just ruptured, and that's why he had this residual mitral regurgitation. So this just shows you that it was correct that we were kind of hesitant to operate him, and that he was not an easy case to operate in the first place. But anyway, a case which did go well despite the fact that it was a very complicated procedure. So let me now go back